Hi everyone, my name is Vanessa Siega. I am a third-year medical student at Burrell College of Osteopathic Medicine. Thank you for taking the time to listen to my poster presentation. Today I'll be presenting a rare case of a tubo-ovarian abscess in a monogamous STI-negative 29-year-old woman without a history of pelvic inflammatory disease. I'll briefly walk through the clinical presentation, diagnostic workup, management, and key teaching points from this case. Tubo-Ovarian abscess, or TOA, is a severe complication of pelvic inflammatory disease, or PID, and is commonly associated with sexually transmitted infections and identifiable gynecological risk factors. Approximately 90% of TOAs occur in patients with underlying PID. As a result, TOA presenting in patients without prior PID, STI exposure, or traditional risk factors is uncommon and may lead to diagnostic delay. This case highlights an atypical presentation of TOA in a patient perceived to be low risk and explores important diagnostic and management considerations. Our patient was a 29-year-old nulliparous woman with no significant medical or gynecologic history who presented with 3 days of abrupt onset severe diffuse abdominal pain. Her pain was worsened by movement, palpation, and urination, and was associated with nausea and dysuria. She denied fever at home, vomiting, abnormal vaginal bleeding, vaginal discharge, or prior similar episodes. She reported being married and in a long-term monogamous relationship with no history of PID, STIs, intrauterine device use, or recent gynecologic procedures. On physical exam, the patient was tachycardic with diffuse abdominal tenderness, guarding, and rigidity. Pelvic examination revealed cervical motion tenderness, mucopurulent discharge, and left adnexal fullness. Laboratory evaluation demonstrated leukocytosis with a white blood cell count of 17.85. Pregnancy testing, urine analysis, wet prep, and testing for gonorrhea, chlamydia, and trichomonas were all negative. Imaging played a key role in diagnosis. Transvaginal ultrasound showed a 6.4 centimeter complex left adnexal mass with pelvic ascites. CT imaging demonstrated a thick-walled cystic mass measuring up to 6.8 centimeters with ascites. MRI further characterized this as a left hydrosalpinx with wall enhancement, consistent with tubo-ovarian abscess. Given her tachycardia, leukocytosis, and peritoneal signs, and concern for sepsis, the patient was started on broad-spectrum intravenous antibiotics. A multidisciplinary team was involved early, including OB-GYN, infectious disease, interventional radiology, and gynecologic oncology. Due to the abscess size exceeding 6 centimeters, CT-guided drainage was attempted. However, no drainable fluid was obtained because of internal loculations and anatomic constraints. Despite this, the patient demonstrated marked clinical improvement within 48 hours, including resolution of fever, normalization of leukocytosis, and significant improvement in abdominal pain. She did not require surgical intervention and was discharged on prolonged oral antibiotic therapy with close gynecologic oncology follow-up. This case highlights several important teaching points. First, tubo-ovarian abscess can occur in patients without prior PID or positive STI testing. Second, negative STI testing does not exclude significant pelvic infection. Third, a reported monogamous relationship should not lower clinical suspicion, as sexual history alone may be misleading. Finally, conservative antibiotic management may be effective even in larger TOAs when drainage is unsuccessful, particularly with those with close multidisciplinary oversight. In conclusion, TOA may present atypically in patients perceived to be low risk. Maintaining a high index of suspicion, utilizing appropriate imaging, and involving multidisciplinary care teams are critical to timing diagnosis and management. This case demonstrates that antibiotic therapy alone may be effective in select patients when drainage is not feasible. That concludes my poster presentation. I would like to sincerely thank my mentors and attending physicians, including Dr. Newmarch, Dr. Leeson, and as well as the OB-GYN, infectious disease, interventional radiology, and GYN-ONC teams for their guidance and their collaboration. And thank you so much for the reviewers and the listeners for your time and attention today.